as a surgical resident, I think, or maybe it was as a junior attending doing nutrition. And while I was at the University of Wisconsin, I got to sit on his lap and he got to tell me nighttime stories about nutrition. And so I borrowed very heavily from basically his compendium of study since the late 1970s. So you might say that this is somewhat biased, but I think it's a different tack on what we normally talk about with nutrition. And so I thought it might be a reasonable idea to talk about the GI immune system and the role that enteral nutrition really should play in critical care, but in the care of any patients. What you'll notice is that a lot of this is actually coming from a surgical background, and that's because, I don't mean to sound biased, but I think the preponderance of the nutritional research has actually come from a surgical background. Mainly because of the heinous things that we do to the bowels on a regular basis. Hey, I'm just kind of killing some time before people arrive. How was the last talk? Oh, was it really?
Well, yeah, that's right.
Sure. All right. Well, this is a slightly different take on GI, and also a slightly different take on nutrition. And I was just saying that, at the end of your fellowship here, or end of your first year or whatever, that it's probably reasonable to assume that you guys have already worked through a lot of the practical aspects of nutrition. But these are more of the theoretical and evidence-based underpinnings for a lot of the things that you're doing. Hopefully we'll get out a little bit early today. This is a topic that can go on for quite a bit, but I just grabbed kind of a grouping of slides so that we can talk about this on a shorter level. So the GI immune system, we have known for a while that enteral nutrition decreases sepsis or decreases the associated factors that come from the septoid patient. And just doing a short PubMed search in the past 2 years using the terms enteral nutrition, sepsis, and outcomes, you have case after case after case after case after case after case. The amount of information that's been published over the past couple years has been voluminous. So much so that it would be nearly impossible to keep up on all of it. And I think Joe would probably agree with me that it is a fast-moving field that is extending very deep into the biochemistry underpinning it. I think the other side, the more practical application of why we do it, is perhaps more important. So it's been known for a while that poor nutrition or various states of malnutrition are well associated with postoperative outcomes. This is a nice study where they took out of Memphis, where they took an unselected grouping of surgical patients across a variety of different surgical service lines, and they just looked at the albumin when they came in at time 0, and then what their incidence of complications was after. Very coarse outcomes. And they saw almost uniform inverse relationship between albumin level, which was their surrogate marker for nutrition at the time, and the incidence of complications, getting up as high as 100% once you drop down into this very severe protein calorie malnutrition. When they broke it down, they actually did something interesting, taking a look at the levels of albumin and how that correlates to ICU length of stay. Lower albumin levels nearly doubled your length of ICU stay. Lower albumin levels nearly tripled your length of hospital stay. And this is just totally unadjusted statistics as they're looking through this. And so it begs the question, what are we actually doing to these patients when they're admitted? And even in a non-surgical ICU, there's this very nice poster oral presentation that was given at Jean-Louis Vincent's ICU symposium in Brussels in 2008, where they looked at all comers in their ICU, mixed medical surgical ICU, lengths of stay greater than 72 hours, and they looked at what they calculated the appropriate amount of caloric intake should be for those patients. And they took a look at what the average intake for those patients was. The calculated intake was, by ESPEN guidelines, recommended to be somewhere around the range of 1,500 kilocalories per day for these patients, and they were getting 300 over the course of their stay in the ICU. And not even a tenth of what their calculated protein intake should have been. In fact, they found out in those first 3 days alone, most of those patients had a deficit, a caloric deficit of nearly 10,000 kilocalories. And look at the mortalities, 14% ICU mortality in these patients who had a caloric deficit of 10,000. Now that, again, unadjusted statistics, and statistics is a very heady sort of field. You can get the statistics to say a lot of things a lot of different ways. This is probably the most coarse adjustment of all. We're not even going to cross-match for anything. This is just looking blandly at the numbers. And I think all of you would agree that a 14% ICU mortality is probably not good. Their takeaway point is this was a pre-test prior to them starting a nutritional management service and actually getting these patients on more aggressive nutritional support, either parenteral or enteral. Now we know that parenteral nutrition is a good thing. Going back to the seminal studies by Dudrick from the late 1960s, where he showed first in puppies and then in babies that you can actually create a survivable situation in these patients that are otherwise uniformly non-survivable because you have no way to give them nutrition. He was able to show that wounds heal. He was able to show that they can survive to leaving the hospital using parenteral nutrition. It's a good thing. It's an option when there are no options. Unfortunately, through the 1980s and into the 1990s, there was indiscriminate use of total parenteral nutrition. And some very thoughtful research had to go on to take a look and see whether or not we were harming these patients. And we know that parenteral nutrition harms these patients, right? These are the most complicated patients that we have. These are the most complicated nutritional states that we have. Vascular access has its complications. There's metabolic complications. There are infectious complications. I argue that TPN is perhaps one of the most complex medications that we use. And to use it indiscriminately is going to start to take on all of these complications. But that's a gestalt, right? We didn't really know that for certain until we looked more closely at things. For instance, the cholestasis that happens with TPN. And actually, aside from the cholestasis, which was the thrust of this paper, I think that the final line in this paper was actually quite telling. Our results confirmed that the number of infused calories directly contributes to liver toxicity in parenteral nutrition patients and strongly suggests that there is an inflammation that is produced as a result of TPN. Now, is the TPN itself producing inflammation, just like we're learning with normal saline causing endothelial damage and things like that? We don't know. We didn't know. We now have an idea that that may be an association that comes from something else. One of the landmark studies that took a look at this was the VA nutritional study from the early 1990s. They took nearly 400 patients and they randomized them to two groups. One group got, and this is again surgical patients. One group got 85% of their caloric needs with hyperalimentation through TPN prior to coming into the hospital, in addition to allowing them to have whatever amount of enteral intake for 7 to 15 days preoperatively. The second group, they managed just like they normally did. They let the patients eat or drink at what they were normally going to do, but they did not optimize them with TPN. What do you think the results were of this? Well, TPN had a huge amount of infectious complications, twice the normal of these patients who otherwise weren't getting TPN. The control was actually equal to TPN for major non-infectious complications as well. And this being a surgical population, this was anastomotic dehiscence, this was wound complications, this was deep organ space infections, which actually fell into the infectious category, which on its surface looks terrible. However, they went ahead and then they stratified these 400 patients in terms of their nutritional status. Now, at the time, they were using a different type of measure of nutritional fortitude. What was it? The NPI, the something nutritional something index, where it was a modifier of albumin level and adjusted body weight versus what the weight they were supposed to have. And they stratified them into borderline, mild, and then severe malnutrition. When they reran the statistics, they actually found, they found that in the severely malnourished patients, that when they looked at major infectious complications, there was no statistically significant difference in infectious complications for the severely malnourished patient. However, when you look at non-infectious surgical complications, those complications dropped by half in the patients that were receiving optimization of their nutrition. Now, I just got off of a tangent of saying parental nutrition is terrible, right? But nutrition by itself, very important. And I think the takeaway points of this study were foundational. One, TPN should not be blanketly applied to these patients. Borderline nutritionally deplete patients, mildly nutritionally deplete patients, TPN inherits all of the risks and perhaps none of the benefit. But two, TPN to the malnourished patient benefits healing rather than incurring infectious complications. It raised the important question that was trying to be answered through the 1990s into the 2000s. How do we identify the malnourished patient? And I think you probably have looked over the course of this past year and seen for yourselves that there are a number of ways to assess whether or not your patient is frail or not, and that's an emerging field. But even by Gestalt, we know that in the surgical patient, most of these patients are not coming in malnourished. Yet they're still having these complications, and nutrition and the malnourishment that happens during the hospitalization is important. Even if they've been optimized preoperatively, they tend to have a progressive deterioration postoperatively. They have a delayed return of GI function, even in neural cases, but most certainly in abdominal cases. It aggravates their comorbidities. It increases infectious complications. It increases non-infectious complications. But we know from that VA study that these aren't the patients that we give TPN to and that we nutritionally optimize. That's not going to do anything. We have to do something after they've arrived. What about the non-elective surgical patient? And in fact, most of this research has come out of the trauma literature, not just the general surgical literature. These are otherwise healthy, and I implore all of you to come through the trauma service at some time. You'll probably see that our opioid-addicted or meth-addicted population that are getting in street fights or other sort of assaults are not necessarily healthy. They're reasonably nourished, but they sustain injury instantaneously either blunt or penetrating, and then their hospital course starts at that point. They begin to have a hypermetabolic process, they have increased oxygen consumption, they have mobilization of the protein compartment. Doesn't this sound like it translates even over into a more medical ICU with any sort of infectious complication, cardiac, pulmonary complication, neurologic complication? These patients take a hit and then fall. In the ICU patient in general, we give them antibiotics. We change their microbiome in their GI tract. We intubate them, and after intubating them, we say, you know what, they were tenuous beforehand, and they're tenuous now, we're not going to feed them, we're just going to let things settle out. We put in NG tubes, and we start pumping nutrition out of every single drain. We deplete protein-rich fluid from every orifice. We give them medications like PPIs that change the milieu of the enteral system. We give them pressors that redistribute blood flow preferentially away from capillary beds that allow their GI function to be maintained. We derange GI physiology. And I would argue that that actually sets us up for failure. All of these sum to a patient vulnerability to massive complications. Throughout the 1980s, the trauma literature has started to take a look at whether or not optimizing patients, in this case animal models, can actually improve mortality, especially with respect to sepsis. In this particular study, they gave rats peritonitis, and they took the well-nourished rats and they would inject either olive oil or they would inject Pseudomonas or E. coli into the abdomen, give them an overwhelming peritonitis, and see how they did. 66% of the normal well-nourished patients, rats, were able to survive the E. coli peritonitis. 15% of the objectively malnourished rats kept without nutrition for between 5 and 10 days pre-peritonitis survived. However, when they re-fed the malnourished rats after they had been induced with peritonitis, they got back that original survival from the regularly nourished patient. If they gave them TPN, the survival actually dropped to like 5%. They took it one step further. They said, well, is there something in TPN that is actually making these patients suffer more, aside from the gestalt? And they had these rats then take the parenteral nutrition orally and put those ones against the patient's rats that were getting TPN. And they found that they were actually able to get nearly back to that original survival if they had those rats take parenteral nutrition, same parenteral nutrition, orally. Well, why should that work? What about the GI tract is actually allowing those patients who are getting the same amount of calories just through a different mechanism to survive? They did this subsequently in a human study. They didn't inject olive oil. They didn't inject E. coli. They did it in a population of trauma emergency general surgery patients. And they looked at early enteral nutrition. And they found that in these patients in the ICU, when they were feeding them within 48 hours of their injury, starting nutrition early, even if they're on the vent, even if they're on a low level of pressors, they were preventing wound adhesions. They were decreasing pneumonia complications. They were decreasing organ space infections and multi-organ dysfunction. It cut them by half at the University of Colorado. So it begs the question, what is the gut role in immunity? And we all know that the gut is the major player for the development, production, and maintenance of IgA stores. IgA, as we know, is part of about 15% of the total immunoglobulin complement. It is mucosal-based immunity. It's produced from the lamina propria throughout the abdomen, throughout the small bowel, and it's concentrated in Peyer's patches. The Peyer's patches has suddenly become a very complicated area. We have the patches in the crypts of the intestine, whereas the majority, about 80% of enterocytes, are on the villi and on the brush border and producing things like mucin and other parts of the immune system. The Peyer's patches themselves have enteral neuronal cells that take care of their tertiary regulation and have a huge concentration of antimicrobial properties. The mucosal barrier itself is a number of cellular components composed of columnar epithelial cells, goblet cells, enteroendocrine cells, and Paneth cells, as well as a cadre of chemical components such as the tight junctions, which prevent migration of bacteria and other larger macromolecules through into circulation, however maintain water homeostasis back and forth through the intra and extravascular compartments. The columnar epithelial cells, they're 90% of the alimentary tract. They produce in and of themselves antimicrobial products such as defensins. Goblet cells, in fact, play a large role in innate immunity as well, allowing for the production of the glycocalyx matrix of the intra-abdominal space, or of the small bowel space. This allows for bacterial suspension. This allows for bacteriostasis, not necessarily bactericidal. And they have a roughly 3 to 5 day turnover. Enteroendocrine cells are about 1% of the epithelium. They regulate the Paneth cells and have high levels of the toll-like receptors and antigen presentation cells in their cellular membrane. But the biggest workhorse is the Paneth cell. Paneth cell has a much longer half-life, 20 to 30 days, whereas the rest of the mucosa has a much higher turnover and a much higher rate of slough. They reside in the crypts. They release antimicrobials at concentrations up to 1,000 times higher than the minimal inhibitory concentrations. Things like lysosine, things like defensins, and products of the Reg3 cascade. They protect intestinal stem cells, and loss of function, which has actually been implicated in Crohn's patients as a genetic underpinning of Crohn's disease in terms of Paneth cell dysfunction. Loss of function results in a panenteritis. In addition to the innate immunity, there is the adaptive mucosal immune layer. This is composed of MALT and GALT. GALT is the gut-associated lymphoid tissue. It is dependent upon IgA production, but also produces the IgA, which allows for opsonization of bacteria. It produces intestinal clearance of bacteria. It resides in Peyer's patches and allows for the lymphoid aggregate and B-cell maturation. It also is the major location of luminal antigen sampling. As you can imagine, all sorts of things go in children's mouths, all sorts of things go in our mouth, and must be dealt with as it goes through our GI tract. Otherwise, there's an overwhelming amount of compromise. Then you have the intestinal microbiome. You have the normal flora of the GI tract. Bacteroides, coliform bacteria, they exist to the tune of 10 to 100 trillion microorganisms. The density increases as you go further distal in the GI tract, meaning that there's much greater concentrations as you get closer to the colon and to the rectum. They facilitate digestion and nutrient absorption. And in fact, compared to normal human cells, there are about 100 to 150-fold more bacteria in your GI tract than there are total cells in your entire body. This all allows for a concept of competitive exclusion from the mucosal surface. And so in the ICU, when we put these patients on broad-spectrum anti-infectives, when we knock out that normal flora, when we get rid of the competitive exclusion, we allow for other bacteria to overgrow. Bacteria such as Acinetobacter species, which degrade the glycocalyx membranes themselves and allow for bacterial migration into the small bowel wall. Circling back around to IgA, the question comes up, well, why would improved GI immunity actually improve systemic immunity? Except for the whole idea that we have a better barrier to the outside world. Well, it became noticed that when IgA gets produced in whichever mucosal bed that it's produced, it is picked up through that lymphatic network. It's brought back to the lymphoid tissue, put back in through the thoracic duct into systemic circulation, circulates widely, and then oddly enough, when it is radiotagged, it ends up in other mucosal beds. And it doesn't even have to be from a pure conceptual standpoint. We know that this happens with the polio vaccine, right? We give people an oral polio vaccine that produces IgA that shows up in the respiratory epithelium to prevent colonization and sequelae of polio there. In fact, IgA will spread from the intestine to the nasal, from the nasal back to the intestine, intestine to respiratory, respiratory back to nasal, respiratory to genitourinary, back and forth across all of mucosal beds. One gets affected and it's herd colonization of your entire mucosa. And so when you take a hit to one of them, when you deprive one of those compartments, the GI, for example, you deprive, in fact, the whole rest of the compartments, especially when you take into account that the GI system produces the preponderance of IgA. So then why does NPO cause complications? It decreases blood flow to the intestine. So if you're shunting blood flow away from the intestine, even if you are still producing IgA, that IgA is not going to be redistributed. It decreases antigen-mediated stimulation of the Peyer's patches, decreased IgA release, decreased mucin production, decreased gut hydration. Acidosis changes the proteasome of the entire GI tract, and in turn, the rest of systemic circulation. And immune enterocytes layer quiescence develops. You have essentially full dysfunction of the mucosal immune barrier complex by making someone NPO for extended durations of time. Essentially, you change the host bacteria imbalance in that patient, not just within the GI tract, but systemically, and you make that patient better able to sustain further injury. Low levels of inflammation develop. You have first hit, whichever the inciting hospital condition may be, CHF exacerbation, polytrauma. That results in circulating activated polymorphonuclear neutrophils. And then those primed neutrophils actually allow patients to get a huge second hit. And I stole this from a separate presentation, but I think we've all seen this cascade before. In severe organ dysfunction, you have a cascade of activation of different levels of humoral protection. Neutrophils are your earliest one, and that 4 to 24-hour activation of neutrophils allows for the primed neutrophils to be circulating, and they're just waiting for that second hit. That was actually a term that was coined in this study from the mid-1980s, where they were, again, looking at traumatically injured patients, and looking to see in the serum of these traumatically injured patients whether or not the neutrophils become primed, looking at that first hit. And then once those neutrophils were primed, once they took them out of circulation, once they put them in vitro, and looked at a second hit, a second activating factor, they found that the PMNs took roughly half the amount of time to start producing massive amounts of superoxide. So you now have this circulating group of cells after their inciting hospital event that are just waiting to provide major oxidative reactions within systemic circulation. Their final words were thus: data from the study showed that the PMN's priming to be a universal early response in trauma, but by extension, really any severe compromising medical state. This observation supports previous finding in animal models that suggest that infection and injury serve as a first hit that primes these neutrophils and disposes the patient to further organ injury. The first hit, cardiac events, sepsis, oncologic trauma. The second hit, is it our hypocaloric response to how we're getting these patients settled in the hospital, thus leading to a further loss of gut immunity, altered microbiome, and further setting these patients up to complication. This is a nice study from the late 1990s that showed that you actually can recover this lost GI function by nutritionally repleting these patients. Now, in some situations, that has to be done with TPN. And to slightly renege on where I started from initially with TPN, these patients were repleted with TPN afterwards, and we found that the cellularity in the Peyer's patches actually came back very nicely. However, to take one more swipe back at TPN, as opposed to making a push for enteral nutrition in the critically injured and the critically ill patient, this study right here was kind of interesting. They immunized patients for Pseudomonas infection, not patients, rats. They immunized rats for Pseudomonas infection, and then they gave them Pseudomonas pneumonia. In the non-immune patient, they had nearly a 75% mortality without immunizing them. If they immunized them and gave them TPN, those patients still had nearly a 70% mortality. However, if they immunized the patient and they fed them enterally, that patient's ability to resist pneumonia dropped their mortality down to the 10% range, either with a specialized enteral diet or the standard chow function. Which allows us to put in context what we try to do on a daily basis when we try to get nutrition to these patients that are under our care. And when we try to look at the different composition of kilocalories that we're going to be giving, whether we're going to be giving them that early protein delivery, or whether we're going to start to back off on nutrition, or at what point during their hospital stay are we going to ramp up the nutrition versus ramping it down. For those of you who weren't here when I started talking, this is heavily based off of, and if you look through a lot of the citations that I put in there, the research of Ken Cust, who is at the University of Wisconsin and is actively looking into GI and mucosal-based immunity and various nutritional states. I would highly encourage taking a look at this review right here. It's about a 40-page chapter looking at the role of GI immunity, and it goes over a lot of what we talked about today. And with that, I'm happy to take any sort of questions. All right. Well, thank you very much for having me today. Congratulations on getting a year under your belt and for some of you completing the Critical Care Fellowship. And if there's any questions or any concerns that should come up in the future, the trauma service and in particular myself, we're available at any time if you want to talk. Thank you. No, I took 2 days. I heard him get that talk probably about 5 times. Oh yeah. And it's okay.
It's probably like on day one. Not people like his exit. He's never going to have normal language. It's not going to be violence. And the one year was more Muslim. Who was here? But what he was about is, his title by people can see. His title by like dead space. It's no good to me.
Who all was here? I mean, yeah, I know Mark was online. Who else was in the room?
Me, Luigi, Karen came forward.
Manny did?
Karen was there, Luigi was there.
Karen, okay. I saw Richie. Anybody else?
Anyway,
No.
and I was there.
Okay.
No,
Thanks.
attending that, he's the one she showed me, but she's going to.